Welcome to a Peer2Peer podcast supported by Rayner. Today I'm joined by Dr. Rajen Desai to discuss the use of the EMV IOL in eyes with mild comorbidities. With an aging population, we're doing more and more cataract surgery, which is great. However, the aging population also means seeing more eyes with chronic diseases, including glaucoma. This makes it even more important to know which IOL to use in the right patient. So let me start by introducing our guest, Dr. Rajen Desai, cataract and glaucoma surgeon with the Whitland Centre for Advanced Eye Care and Santa Maria Eye Centre. Thank you, Rajen, so much for joining me. How are you?
Great. Thanks for having me, Ben. Appreciate it.
Well, you're a cataract and glaucoma surgeon, so you're perfectly placed to discuss that crossing of the Venn diagram of cataract and glaucoma. And you've dealt with a lot of complex cataract cases over the years. You're a very experienced surgeon. So would you mind sharing the secret sauce when you're planning cataract surgery for these complex patients? What are you thinking about?
Right.
That's a big question. That's
It's
a very
big
big,
question.
wide
And
open question.
people, my staff always wants the method to the madness, and some it feels like it's madness. I try explaining, what to do. It's kind of like saying, playing football. Like you have to be a quarterback, and you have to choose. You can't just pick your best friend who just throw the ball every time. You have to think, which of 8 different receivers you throw to. Sometimes you don't throw the ball at all. You throw it away. Sometimes you run the ball. There's no recipe for what you have to do. To have experience, you have to have failed, have complications several times, and learn from your mistakes, learn from patients. At the end of the day, you may not win that drive or may not win that down. You have to win that game. And our goal for patients who have glaucoma cataracts is that when they pass away, they should have the best possible vision in that was given them with the technology we had available. The ideally thing we are going to do for our patients is that we should be able to control their glaucoma as much as we can so that there's very little impact to their vision-related quality of life. That means the type of way we treat the glaucoma, both with drops and with surgical choices during surgery, and always the type of lens we use also. You don't want to put a lens in that seems great now, but you will regret in 10, 20 years. So it's a fine art. So I think the way I approach it is like when someone comes to you with glaucoma and cataracts, the cataract parts we know about. But the glaucoma part, there's often a large group of patients who don't have glaucomatous optic neuropathy. And that sounds like a very academic term, but like their nerve is not sick. This is someone who has a 0.4 cup-to-disc ratio. Their pressure was a 22. Pachymetry is 570. But they're using timolol every morning because they've been told they have glaucoma. And now that patient, and they're +3 hyperope. Their anterior chamber depth is 2.1 millimeters. Everything's telling me that this patient's pressure will drop unmedicated, just cataract surgery alone. But because they've been told they have glaucoma, they were told they feel like, and sometimes doctors feel, oh, they must get a monofocal lens. This person is now stigmatized the rest of their life. They can never benefit. This person's like 63 years old. And now for the next 20, 30 years of this person's life, their retirement years, they got to read the menu, with glasses on. And do you really want to do it to like that generation, to retire and need glasses? If you need glasses, you need it. And you have the means to pay for it, you can avoid it. But I really feel like we should find something for those patients. So that patient, in my opinion, does not have glaucomatous optic neuropathy. There's no damage to the optic nerve, and there's no reason to suspect decrease of contrast in a nerve either.
That's like the super mild end of the spectrum. For those ones,
right.
You don't treat them any differently to a standard cataract.
Mild, I don't even do a MIGS on them. I think you first do no harm as a surgeon. So I don't believe ethically in doing a MIGS on a patient who does not have glaucoma.
Yeah, that hurts my bank account. But
right.
I agree. But I agree with you morally. I completely agree with you.
Right.
With those patients, you're taking any kind of gamble. Like, do you think, right, I kind of am a bit suspicious of this patient, but I'm sort of saying they should be fine.
Yeah, I'm 43, so it's not my first show on the road, but I'll be with them for the next 20 years. So I own this, like the results, the choice I make during surgery, I'm not going to say it's going to be some other person's problem in 10 or 20 years. It'll be my problem in 10, 20 years.
You're not really gambling.
Right. It's not a gamble because I have the cards. I'm in the 20-year poker game, and if you own the casino, you're going to eventually win. So yeah. So for those patients, I feel like if you have mild glaucoma and the patient physiologically has a low risk of progression, means that they don't have sleep apnea, they don't have low blood pressure, ocular vision pressure, they're very compliant with eye drops, and they don't have, the mother went blind, they don't have a thin pachymetry. These are physiological factors the patient can't control. That's just their own physiology, a high risk of progression. If they don't have those risk factors, and you as a surgeon has a good mindset, or you'll easily refer to a glaucoma specialist to put a trab or a tube if you feel you needed to. You're not going to hold on to the patient unnecessarily. Then these patients are great for having some lens that gives you enhanced depth of focus. And I think that's where the Rayner lens comes in very nicely.
Can I ask about the elephant in the room, which is using the EMV lens, which is hydrophilic. And hydrophilic lenses, I'm a big advocate of them. I like them. I think there's some benefits to them. But people talk about opacification. And especially with other procedures, bubbling of DMET grafts, gas inside the eye. Personally, I'm happy putting in eye stents at the same time. I don't really get more interventional than that because I really am treating probably that first group of patients where maybe I shouldn't be. But, what are your thoughts on combined procedures with a hydrophilic lens inside the eye?
Yeah, so I think like if someone has severe stage glaucoma, or someone has a high rate of progression because of either non-compliance or just access to care, or whatever reason there is, if I feel like this person in the next 10, 20 years will probably get a tube shunt in her eye, like someone who has pseudoexfoliation, high rate of progression, someone who has neovascular glaucoma, then I feel like, no, I would rather not use a hydrophilic lens in those severe cases. There's some patients, they'll be fine. Here's some eye drops, come back in 4 months. 99% of glaucoma patients are stable. They're going to be fine. And so the majority of people, 95% of people can be just fine with just a hydrophilic lens. Very rarely, I think you should just get them that avoids that.
For a cataract surgeon like me who doesn't know that much about glaucoma progression, really hates visual fields, likes to watch an OCT, and you do have that mild patient where you think, oh, you do have glaucoma. I've inherited you. You're on latanoprost. You're doing okay. I think that I'm doing your cataract surgery, and I probably could get away without any kind of MIGS. Do you think that for those patients, there's a way of, I suppose, predicting whether their degree of glaucoma will impact their ability for me to use one of these more advanced lens types like the EMV or a trifocal?
Yeah, I mean, so, right. I think it's like, for a mild patient or a moderate patient who has good stability, which are a majority of patients. I think like in a comprehensive doctor's practice or refractive surgeon's practice, probably 95, 98% of people with glaucoma have this. So I think they'll be absolutely wonderful. I think like the only time you kind of worry about if this patient will suffer a reduced contrast.
When people are listening to these podcasts, they love, love, love to walk away with like a snippet, like a perfect piece of information. And this is a terrible question to ask because I don't know the answer. But say you've got a patient sitting in front of you and you're thinking, right, they do have glaucoma. It's moderate. Um, are there specific measures or thresholds where you look at it and you say, no, no, you're getting a monofocal lens? Is there anything like, maybe it's visual field defects closer to fixation, or maybe it's a particular level of progression? Are there any particular measures preoperatively which really throw your decision making where you think, right, I've seen that? No, you're getting the simplest option.
Yeah, I think there's probably four things that I would recommend. Those the people who actually are very high risk of having their glaucoma involving fixation. So that's someone who will suffer a vision-related quality life suffering from it, and that's someone who actually is a high myope. So myopic people, they often have normal tension glaucoma. So even when you feel that everything is perfectly, they're still progressing regardless. Second is the pseudoexfoliation. Those should not get multifocal lens because the lens can decenter on its own, but they can progress very rapidly. And they get suddenly the pressure is 24 or under in the teens for years. And one day they show up in your office and it's 50. And you never know when that happened. They had no symptoms. And so pseudoexfoliation is number two. Sleep apnea or low blood pressure. Those are people who actually, in spite of their IOP, remember, you're looking at IOP, but you're not checking the blood pressure. You're not checking for perfusion pressure. But we now know more and more, a little bit now, but definitely more in the future, of how sleep apnea and low ocular perfusion pressures, which is typically a surrogate marker for the low diastolic blood pressure. And we don't know that, but I kind of look at the thin, small, frail woman often has a low blood pressure. I think you're going to progress. And if you already have glaucoma, your pressure is 13, you're going to progress. And so those are for candidates also. Anytime a visual field defect is encroaching fixation. So the center 4 dots of the Humphrey visual 2 field, that's involving fixation. The next radius around it is encroaching fixation. If I see any dot, whether the light gray, getting near that spot, you're out. Like, I'm not going to be doing the lens on you because I think in the next 20 years, if it's already damaged once, it's going to be hit. That dark gray, that light gray box will become darker and darker and black. That's just the natural course of glaucoma. Glaucoma does that. And so I'm always worried about those sort of 4 factors on patients. I say just avoid it, stick to monofocal lenses.
That's really interesting, but it's also really sad because now I have to do visual fields.
Right, I'm very sorry. Get a virtual reality
All right.
visual field. Those things are great. Those things are
Oh,
great.
true. Are you doing that? Are you doing
They're
that at the
fun.
moment?
We're doing that. Patients like it. There's better and better technology on it. And one good thing is now there's some VR fields they actually, after the test is over, they actually have this like programming, tell touch about visual field, but the different lens options, touch you about femtosecond laser, and about the different MIG surgery. So it does all the chair time for you while they're sitting there quietly.
Wow. Now, Rajen, this is another controversial question. Okay. So, we're talking about loss of contrast sensitivity, and we're thinking, right, we've got someone where they've got a visual field defect that's nearing fixation, so we're worried about them. And we're thinking, right, we don't want to do anything that would harm their contrast sensitivity long term. There's been talk about that lenses like the EMV lens don't actually negatively impact contrast sensitivity. So why should we put in a monofocal as opposed to the EMV lens?
We want to do what's best for our patients. And sometimes we know what's better for our patients. Like, I have two small daughters and, I know what's best for them. I don't care what they want to do. They want to watch Bluey all day. They want to watch Bluey at 9 o'clock at night. No, you're going to go to sleep. I know what's best for them. But sometimes you got to be careful when you have a patient that just because you've been taught a dogma that you can look someone in the eye and say, I'm a doctor. I know what's best for you. You must wear glasses. You got to sometimes shave off a little bit of ego at times and say like, what makes you happy and what actually is your quality? What are your needs and your quality of life? I mean, we don't even know what causes glaucoma. And do you know what the treatments are in 10 years? 10 years ago, we didn't even have an eye stent, and like what's going to happen in the next 10 years? We're treating a person's quality of life, the vision related quality of life. That's the whole point of treating glaucoma, is to maintain that level of happiness. And then, not to be patronizing or anything, but like if someone really enjoys their happiness of not needing glasses up close, that's a good thing. So I do think like we should be careful about us saying no. Trouble is like what's the worst thing that can happen to a patient vision related is tripping and falling down the stairs. So I just stepped outside my house to get the paper. I don't use my glasses for that because they're a -3. You'll trip and fall also. So now because you gave a patient a -3 target and now she tripped and fall, was it really, really worth it to them? You could have just given the darn EMV lens and have far and arm's length, and they could still be able to read, at least not at 12 inches, but at 18 inches, 20 inches, and now they would have seen the stairs. So again, like, think about what's best for that.
Yeah, I mean, like you say, 10 years ago, 10 years in the future, who really expected that glaucoma would be sexy? I mean,
Right, that's
you know,
right, exactly.
I mean, who saw
Oh,
that
the
coming?
doctors.
I mean, the best specialty is always meant to be refractive surgery. I'm disgusted, but
I know. Finally, we got you. We got you.
glaucoma has become so cool. I hate it. But it's cool. There's all these new treatments. It's awesome.
Right, right.
Um, Now, Rajen, you've conducted a study, I understand, about the RayOne EMV lens versus Vivity.
Mhm.
And obviously, I'm a fan of the RayOne lens. I put it in. So it was developed in conjunction with a great Australian, Professor Graham Barrett. There's a little bit of bias there, but I also used to use the Vivity lens. And um, can you tell us about the study? Can you tell us about what you were looking for, what you found so far, what's happening?
Yeah, people who got Vivity lens with glaucoma, and I cherry picked people who actually were nice and stable and mild and full fields. Then for the EMV patients, I said, they have, again, stable glaucoma, even a little bit, maybe worse, maybe moderate stage glaucoma, like -5 decibels on the visual field defect, again, nowhere near fixation, nowhere near encroaching fixations, a couple dots in the periphery. Then I'm thinking, okay, I'm gonna put a lens inside your eyes, but you're probably gonna need it for up close. And I gave them, and like you would, I trusted Graham Barrett's calculations on all the measurements I do. So like Graham Barrett is involved in making a lens. It's not just the RayOne lens, it's the Barrett one lens, for my opinion. So if I trust his formula for years, I'm gonna trust the lens he makes. At least try it out. Just try it.
Yeah,
So try it out.
he's got a pretty good track record, pretty solid.
Pretty
Yeah.
good. I mean, so I just tried out there. And I was surprised and shocked that these people were shocked that they're reading 20/40.
In freedom units, that's like, what is that? Like half a French fry?
So what I tell patients, like let's say you have an iPhone, at 18 inches away, the size of your text is 20/40. Right. So in fact, you will not see 20/20 because you have glaucoma. They're like, oh yeah, I know I'm not gonna see 20/20. That's fine, doc. But typically, I noticed that they actually can use their cell phone at 18 inches away with both eyes open. And so, and that's functional. Anything smaller than a text message, put on glasses. But like, if I can text and read emails, not, it's not subtitles in emails, but just normal emails and text without wearing glasses, and I can see enough to drive without glasses far away, that's a slam dunk.
Yeah, that's awesome. That's all anyone wants.
So I did the study on those patients, and they're pleasantly surprised, and they're reading like their cell phone with the dominant eye, just the week after surgery. When I made their other eye minus 0.5, which we kind of do anyway, a lot of us do this mini monovision sort of thing.
Yeah.
And I realized that, wow, this actually is working. And I asked him nighttime glare and halos, obviously nothing. There's nothing out. There's no rings. There's no diffractive rings out there in service. And I knew I was giving a monofocal like lens. So I know there's no decrease in contrast for forever inside their eyes.
Yeah.
And so I was pleasantly surprised. So then I started doing a retrospective study where I had, about 20 patients on the Vividity lens. I had another like 100 patients on the RayOne lens, all criteria, and results were again and again. And so the end of the day was like, only 8% of people with the RayOne lens needed to wear glasses for their cell phone for reading. And also like even for nighttime driving. So a lot of people like they drive at nighttime. Now you're 60, 70-year-old, they're driving around. So yeah, for those patients who really cannot handle glare and halos, I mean, you're not going to have that, period. There's no rings on it. There's nothing central about it. It's a nice smooth contour from the center to the apex. There's no cutoff whatsoever. And sure enough, not a single complaint has ever happened from that.
I purely have anecdotal evidence, so I would love to know the true objective evidence from your study, but I used both lenses and I found that Vivity gave me more range, gave me a little bit more depth, but I also found that the EMV gave my patients better vision quality for distance. Sort of I was getting more 20/20s and than I was with the Vivity. And so I think we are judged on distance vision quality. There's an element of being judged on range of vision, but ultimately people love really good distance vision. And I wouldn't be negative about any lens, but I've been really surprised by how good the quality of the distance vision has been with the EMV. Did those results come out in your study at all?
Totally. So now that was a retrospective study. One thing I did not, and I noticed what you're mentioning, Ben. And so the biggest reason I see difference is the pupil size. So when patients see me on the second visit is undilated, because then I can judge the pupil size. You'll be surprised how many people, even when the room lights are dim in the lane, it's like a 2.2 millimeter pupil. The trouble is the Vivity lens central ring is 2.2 millimeters. The Sentry is 2 millimeters is for near. And so if someone's walking around, especially in a bright light, when they're driving outside their car, they're 2.2 millimeters, they don't have distance and they complain, hey, I can't see. And that's why the biggest difference in quality size, because at distance in a bright environment, if they have not a nice blue-eyed patient who has 5 millimeter pupils, but they have that 2 millimeter, 3 millimeter pupil, a lot of the light's going to go to near, not to distance. But the Rayner lens, there's no cutoff. It stays a little bit positive spherical aberration and it smoothly contours down. So I don't have to worry about pupil size at all.
I completely agree. I don't think we're looking at it. And all these lenses that people are talking about being pupil independent, there's no such thing. If we have a smaller aperture, we'll get more depth of focus, but also we're going to limit to the central elements of the lens. I mean, you can tell, even when you put an EMV lens in, the next day, if they're still dilated, the vision's a bit average because they've got a lot of spherical aberration. So I completely agree with you.
What I thought about doing, I'm actually in the middle of it. IRB is already written up for doing a randomized controlled trial. And this I'm more excited about. So now where I'm doing a randomized controlled trial where basically the patient is masked to the lens they get, and my observer is masked to the lens they get. And they sign off. It's people who have mild to moderate glaucoma, so I can cherry pick only people I'm not worried about. And the patient for 1 month is not allowed to get their card to see what lens they got in their eyes. It's 50/50 is a flip card. I want to take the time to do the study right, do it cleanly. I'm blinded to it. I'm not going to see the patients afterwards because I'm biased. I know who has what. I'm just like pure data, objective data, and just get it from them. And so I'm excited. We're in the process of doing that stuff. Yeah.
I think that'll be a very well-read study. It'll give us a lot of information because that's really the comparison that people want to see.
Double-blinded, randomized control trial. That's how it is. I mean, that's what it takes to do glaucoma. So the same level.
Is it difficult with a glaucoma study? It's such a heterogeneous group. Is it difficult to qualify people, or?
Yeah, it is, because people, and I'm very, very conservative and trying to be on the safe side. So if I'm worried about you, and I'm worried about everybody, if If I'm really worried about you that I'll need to do a tube shunt on you in the future, you're out of the trial. I need to know that I can look at you in the face 20 years from now, because I'll still be working. 25 years from now, I'll still be working, and say I picked the right lens at the time. I didn't compromise anything. So I don't care if my numbers are low or it takes 2 years, 3 years to do the study. I'm not anyone's clock. I'm not in academics. I don't have to publish or perish. This is my own interest. It's my own joy. Genuine interest. That's the best kind of study.
This is why studies should be done. This is exactly why research should be done, not for the
right. Yeah. When we're in trainees, we get forced to write these papers that we have no interest in. We do it because our peers make us do these studies, and we have absolutely could not care less. And that's,
I wrote some terrible papers.
You should see mine. Exactly. But now it's different when you're a consultant or an attending now, and you at this stage of your career, you can choose what you want to do, what makes you passionate about. And that's what I like doing at this stage. So yeah, I'm excited about it. I knew the results can be amazing. And so Rayner sponsored the study because they said, I told them, guys, I already know the results. It's going to be wonderful. And especially when you segregate pupil size, you'll get even more. And people have smaller pupils, the results will be more difference. The Rayner people can be doing much better in the vividity people, as we talked about, because 2.2 millimeter cutoff.
It makes sense.
So yeah, I'm excited about that. The study is going to have, I think, 30 patients, so 60 eyes on each arm.
Mini monovision or both eyes?
Yeah, a mini monovision. So the first eye, and this is what I do for the vividity patients too, who are good pupil size and people in vividity patients, so more than 3 millimeters. The first eye, I do the -0.2 to -0.4, the dominant eye. And the non-dominant eye, or the non-preference. I know you have a whole ATR podcast on dominance. I love that one. The non-preference eye, the non-dominant eye on the -0.3 to -0.5. So I don't believe in the first plus. I don't feel, I think you can be very confident in the Rayner lens to do that. I don't go more than -0.5 ever because I think at that point you should tell the patient you're doing monovision. And they should realize one eye is not going to be as clear as the other eye. You have to tell patients that. Regardless of the biometries. Typically for the non-dominant eye, I have 2 lenses. They're half a diopter apart. And I do try to see my patients in preoperative, in the pre-op waiting area, just to, hey, how you doing? And read the consent forms and have them read the consent form with their dominant eye, the one I just did, and just see if they can see that. And I kind of tweak the other eye for that. So it's a joy.
I think we're very similar. I think it works, it works for me. Well, Rajen, I was going to wrap things up, but is there anything else that you'd like to talk about? Is there anything else you'd like to ask, or anything like that before I sort of wrap things up?
If it's too scary, too much dogma to go into a multifocal or EDOF lens for glaucoma patients, at least get your feet wet in the enhanced monofocal space. And because you don't have to worry about pupil size, RayOne's a great, Graham Barrett chose it. If you're scared and you're nervous, the guy who made the formula that you use in your OR is the guy who helped make this lens. So if you wanted to, who do I trust? You trust that guy. That's the one I'm using. Try it on your myopes who had to make the hard choice of being plano versus being near. Try it on them and let the patients decide for you, and then delve into that space. So in the end, just like you're innovating surgically in glaucoma, MIGS, try to innovate, or at least accepting of innovations in the IOL space in glaucoma too. That's the only thing I have to say. Your patients will benefit.
I love it. I love it. You've got some very lucky patients, Raj.
I hope so.
You do. So many thanks, Dr. Rajen Desai, for sharing your insights about using the EMV IOL in your practice, and especially for your knowledge about this IOL with complex patients and comorbidities. It's a lens that I use routinely. I'm very happy with it. I'll certainly be using it a little bit more openly, perhaps, with some of my glaucoma patients, thanks to your data and hearing your anecdotal evidence as well. So I think I'll be able to broaden my patient selection criteria, and I think all listeners should be able to too, with confidence. So thank you very much.
Well, thanks for having me, Ben. Appreciate it.
Oh, my pleasure. Absolute pleasure to have you. And thanks to everyone listening for joining us. And I'll look forward to the next episode of Peer2Peer. Thanks very much.
Bye.
Thanks, Rajen.
Bye.